Beth.
This meeting is being recorded.
And also, of course, I just have to say for Dr. Hogan to come back again and again is really a gift to us. So I want to welcome Dr. Hogan. I know this is a new kind of program you're going to be. In the past, we've had you do COVID. You'll probably get some COVID questions, but so I know this is a new opportunity with Emory Decatur Hospital, this transitional care clinic. I'm interested to learn more about it. And Elizabeth, your role and your partnership with Dr. Hogan in this new program. So thank you both and welcome to Central DeKalb Senior Center.
Thank you. Thank you. Should we go ahead and get started?
It's on you. Yeah, go ahead and get.
All right.
Nobody shows up on time.
Oh, okay. Well, I understand that. So for anyone that is just joining now, I did a quick introduction previously, but my name is Elizabeth Nark. I'm the lead development director with Emory. I work with the hospitals and specifically with the hospitals formerly known as DeKalb Medical. So Emory Decatur, Emory Hillendale, and Emory Long-Term Acute Care. I am an Atlanta native. I grew up in town Atlanta and went to elementary school in Decatur and live in Decatur now after going to the University of Georgia. And hopefully we have some dog fans on the call today. So I am going to turn it over to Matt Hogan, who will do his introduction, although I think most people do know him. And we'll spend about 15 minutes talking about this program and also take some Q&A at the end. But look forward to sharing what we have working on with y'all.
Afternoon, everybody. My name is Matt Hogan. I am a board certified internist practicing hospital medicine. I am the medical director of Emory Decatur Hospital and the Emory LTAC facility. I am also the medical director of care coordination, which means I deal with a lot of insurance companies. I'm on the board foundation and I've worked at in the DeKalb operating unit for about 12 years, originally from Philadelphia, went to medical school at Temple, did my residency at Emory, married a Georgia Bulldog fan, and therefore I never went home. So here I am. So I'll just get right into it and feel free to ask any questions at any time. But I think we got a fairly concise presentation. Elizabeth Nark and I have been working on this transitional care clinic for quite some time. So we know a lot about it, but basically, to give you an idea of what it is there's a big donut hole in medicine for our most vulnerable patients, those who don't have resources as critical as insurance and therefore don't have critical follow-up care. And the transitional care clinic provides part of that care. So one of the biggest risk factors for somebody to be hospitalized is being hospitalized. So if you're in the hospital, whether it be the ER or you're admitted, you are much more likely to be admitted or go to the ER again after you're discharged. Doesn't matter. This is all cause. It doesn't matter why you were there in the first place. And so the vast majority of patients who manage to stay out of the hospital have resources to keep them out of the hospital. And one of the main resources is adequate, close, and quick follow-up care. And so our most vulnerable patients do not have that. And so it's the hospital functions almost as a revolving door for some of them. They leave, they come back within 7 to 10 days, and that 7 to 10 day period is critical. So the transitional care clinic is a clinic that we would like to set up for those vulnerable patients, basically to decrease their risk for readmission to the hospital so that they can, and to provide them with critical resources in order to do so. And so here are the core components. So basically the clinic is a standing clinic and it functions as a follow-up clinic, at least temporary for these patients. And what we would prioritize are things that a lot of things we can't get done in the hospital for any patient. So the hospital is a very extremely busy place, not just during COVID times, but outside of COVID times. And the inpatient care providers, such as hospitalists like myself, we don't have a lot of time to spend with the patients to go over every single one of their medications, why they're taking them, how to take them. These things take hours. And we have 20 plus patients sometimes a day, and we just do not have the time to do it. And so a lot of patients, when they get discharged from the hospital, there's a ton of confusion. The education is not provided, it's not stable, and they end up back in the hospital. So a transitional care clinic functions in order to provide care in that respect. We educate well, first of all, when they get to the clinic, we would deal with their acute medical issues, what put them in the hospital in the first place. We would go over their symptoms. We would go over what their medications are and why they're getting treated with the medications that they're getting treated for. We manage their diseases and their symptoms. but we also serve in an educational respect. We basically teach them about their problems. We teach them about their medications. We tell them why what the meds that they're on, why they're taking them, not just the ones that they got when they were recently in the hospital, but all of their medications. We identify any of their concerns. So a lot of their concerns aren't just access to healthcare, it's access to food, access to transportation, access to a pharmacy. And so we provide them with resources in order to deal with these issues that they have. These are disparities of healthcare that are often titled social determinants of health, if you've ever heard that term before. And these are critical, and they lead to healthcare failures if patients don't have access to them. And then we would prioritize the patients. So for instance, patients can't afford medications. We would get them their medications from our pharmacy. We would provide them with cheap and sometimes free medications. So as you can see all around it, it's not just about going over what their individual disease that put them in the hospital was in the first place. It's a sum total care of every aspect of their healthcare life, including, as I stated, priorities, concerns, medications, their current state, also engaging their family members and other community members that care about them to help link them to care. And the most important aspect here is the transitional care clinic is not a continuity clinic that the patients would stay in forever. The goal of it is to move them onto a primary care physician and onto a subspecialty network that is more stable. We provide care in that interim until we can get them to the point of stability. As an example, we have a lot of ancillary clinics around the hospital, such as the Oakhurst Clinic, that provide care to our indigent patients that don't have insurance. The problem with those clinics is they have so many patients that they have a wait time, sometimes on the order of a month or more. And we know from studies that have been conducted over many years that patients that just get discharged from the hospital, if they don't follow up within 7 to 10 days, their likelihood of it being readmitted to the hospital significantly increases. And therefore, our goal is to get patients care within that 7 to 10 day hole, which our community clinics are stretched thin and cannot provide at this point in time. So that is the overarching purpose of the transitional care clinic. Go ahead, Elizabeth.
Go ahead. I was going to say, as Dr. Hogan mentioned, so, a very important part of this transitional care clinic is that warm handoff. So if we did refer a patient to somewhere like Physicians Care Clinic or ethnic clinic in the community, post-discharge, they wouldn't be able to get that follow-up care in a timely manner. And they also may not know where it is. They don't know anybody there. There's not any familiarity there. So with the transitional care clinic, and we got this idea originally from Northwestern in Chicago and have since also spoken to Grady here in Atlanta that has a similar program, is people are more likely to follow up if they're going somewhere that they are familiar with. So if they're at discharge, we're saying, okay, you're going to come back here to this campus and, you'll see Dr. Smith, she's great, and so there's a warm handoff to the transitional care clinic. We do follow-up calls to make sure that post-discharge, 2 days post-discharge, the patient got their medications refilled. If they didn't, why not? Do they need help? What's the barrier there? Remind them of their appointment. Are there any barriers to getting to the appointment? Do they need help with transportation? And will a family member be joining them? That's something we encourage as well. We want to include any care partners that are involved. I know my husband often calls me Nurse Ratchet when I get on him about taking his medication when he is supposed to, but making sure that everyone that is together, knows what that person should be doing is helpful to help set them up for success. And many of, I just threw several logos up here of organizations that we do work closely with or will be once the clinic is open, because it's not yet at this point. But MedCura Health is the new name for Oakhurst Clinic, if anyone's familiar with that. Ethne and Clarkston Clinic are both in Clarkston, as is Grace Village. FODAC is a great organization. If no one's familiar with that, it's located in DeKalb and Stone Mountain, and it stands for Friends of Disabled Adults and Children 2. and they help to provide durable medical equipment, refurbished durable medical equipment to patients at a decreased cost. So crutches, bedside commodes, walkers, that sort of thing. They help get those out to the folks that need them. So we connect them with and wheelchairs and things too. So again, items that this population may have trouble getting because they're not insured, we can help get them what they need to take care of themselves at home or take care of a loved one at home. And another piece too is we will be incorporating some telemedicine in this. Again, as COVID comes and goes, kind of a roller coaster. Some people are comfortable coming to in-person appointments if they need a follow-up visit and would rather do it virtually. We would like to offer that option, but not everybody has Wi-Fi access. So something great that the DeKalb County libraries do is offer, you can check out a mobile hotspot from the library, just like you check out a book. And those have been incredibly popular. People check them out for school, for work, but you can certainly do it for an appointment with a physician as well. Dr. Hogan, anything I'm leaving out here?
I think the beauty of some of the partners that we have is we have relationships with them already. And as an example, the Ethne Clinic, 4 of the providers at the Ethne Clinic are also hospitalists right here in this office. And so we have established relationships with them already. So it should be a seamless transition from the transitional care clinic over to their clinics when the time comes. So community impact, it's incredible actually, what kind of impact a transitional care clinic can actually have on the community at large. When we increase the health of the vulnerable population, we actually improve the health of everyone in the community. I'll give you an easy example. What we see a lot in the hospital are diabetics, especially new onset diabetics who need insulin and have no insurance. We give them prescriptions, we send them home, we try to provide them with resources to get insulin, but inevitably a lot of them cannot afford it and they end up back in the hospital. It's also possible that they didn't get the education on how to take the insulin that they needed and they end up back in the hospital. And so they're consuming beds that had we had a better outpatient resources, they wouldn't be using. And if they weren't using those beds, then we could use them for patients that actually need them, whether it be any of us in the future. So increasing the health of the vulnerable decreases overall hospitalizations, which actually improves metrics for both hospitals and patients alike, including it'll decrease our length of stay, it decreases our wait times, it decreases our readmissions, it decreases our healthcare associated infections, it increases our patient satisfaction, and all of that leads to better health of the community at large. And it also improves the health of our healthcare system. So if our system is healthy, our patients are healthier.
Yep. And, nobody likes to wait to get into the emergency department if you have an emergency, and nobody likes to wait if you're moving from the emergency department into a bed in the hospital, that wait. And, this just is something that really helps with that flow when you help manage the healthcare of people that are using the emergency room for non-emergent care, especially with a lot of these chronic illnesses that we see a lot here in DeKalb County and in Georgia. So it's really a win-win program. And as Dr. Hogan said, we have been working on it for a little while because we had just started to gear up, and then unfortunately COVID hit and, kind of sidetracked and put this on the back burner for a little while. But this is a focus of Emory Decatur, and something we are very passionate about. If you can't tell, when we were told we had about 15 or 20 minutes, it was difficult to narrow down our talking points, but it's something that we love to talk about and we're very excited about, and plan to use the program at Emory Decatur as a pilot for other hospitals within the Emory system that may need a similar program, such as our Emory Hillendale and South DeKalb. Emory Midtown may potentially be a good site for this as well. But just, at the end of the day, connecting patients with the care that they need. And, that's our job. So how can you help? I mentioned it has not opened yet. That is because we are fundraising for this project. So if this sounds like something you might be interested in supporting, would love to have that conversation with you. I've got my name and email address and phone number up on the screen now. There's also a one-pager kind of fact sheet on the Transitional Care Clinic that will be emailed out after the presentation. That also has my contact information. So would love to hear from you, even if you just have some questions or want to learn more. Again, love to talk about this project. Also, likewise, we do have, as far as fundraising goes, we're really excited. As of in September, we had a community member in the community make a very generous matching gift. So gifts up to $500,000 will be matched. So we have the ultimate goal of raising $1 million towards this project. We've raised about 75,000 towards that match right now. So getting towards have about $425,000 to raise, but we're on track. We are looking to open this clinic likely in late 2022 or early 2023. Internally, all of Emory Healthcare, so not just Emory Decatur, but all 11 of Emory's hospitals are undergoing a transition to a new electronic medical records, which is not a small feat. So that has to happen before we can bring a new clinic on. So, but that's our timeline there. And of course, if anyone is, has any other interest at Emory, we do a lot of great things, research and all sorts of things. I'm happy to speak to anyone about any of that. So Dr. Hogan, or do you have anything else to add, or Beth, anything that we may have left out? Otherwise, we can certainly take questions.
I think one more point I'd like to make is that one of the things that I've been thinking about over the past several years, since we become part of Emory, is how do we distinguish ourselves here in the DeKalb operating unit? How do we have our own voice? And I think what we did before and what we still do great here is primary care, and the Transitional Care Clinic falls directly in line with that. We need to make our name for ourselves within the university system, and this is exactly the way to do it. It would be a clinic unlike any other that they have at this point, and this would make DeKalb and the DeKalb operating unit stand out.
That's a great point, Dr. Hogan. One of the things that occurred to me when I was watching the presentation, and I hadn't had a chance to ask this question before, is will there be a mental health component, or will we kind of work closely with that DeKalb Community Service Board and some other agencies to fulfill that?
Behavioral health care is definite, and it's something that we need. We're not necessarily prepared to start out with it immediately. Well, I mean, we have some resources, but eventually it's going to be a robust part of the Transitional Care Clinic. Absolutely. And that's actually a really good point to bring up, because another social determinant of health besides just access to care is actually mental health. So mental health does drive patients to come back to the hospital. Basically, it's an increased risk factor for readmission to the healthcare system, and so it is something that we will definitely focus on.
Good.
And that is, Beth, thank you for bringing that up. DeKalb Community Service Board, if that's an organization anyone on the call is not familiar with, they are a mental health organization that helps to provide counseling services to the underserved, and they are located just on Winway alongside Emory Decatur Hospital. So again, another great organization that we already have a relationship with, and look forward to working with further.
Does anybody have any questions?
Yeah, I've been, all members of my family have received excellent care, both in transitioning out and discharge from Emory Decatur and DeKalb Medical over the years. And I was just interested to see how you contemplate integrating the work of the care managers and social workers in transition to rehab facilities with your program?
It's a great question. And so we will identify a point person in the hospital to identify patients that fall into the category of needing a transitional care clinic appointment. And most of those initially will come from ER physicians and from hospital medicine providers. We would probably pilot it initially for the first several weeks on one floor and the ER, and then roll it out to the rest, and basically have that point person make appointments for those patients in the care clinic. And that would probably be part of our case management team. We also have discharge nurses actually in the hospital already. There's not many of them. We need more. But they also identify patients that need follow-up and help arrange follow-up appointments with them. We have a call center as well. So we have multiple resources that we can rely on in order to provide our patients with those appointments. And we want it to be done in real time when they're still in the hospital, so that they see a representative of the transitional care clinic in front of them. And so it makes it more real. When we leave patients to their own devices, when we say just follow up with your PCP, it often doesn't happen. So that's more of that warm handoff that Elizabeth was referring to, where, we have face-to-face time with patients and with each other in order to make sure that they get the care that they need. They get the follow-up appointments that they need in a timely fashion.
Anything else?
That's I could talk about that forever, but that is an incredibly key piece of healthcare work that we need to do every day, not just for transitional care patients, but hospitals in general need to do a better job of providing follow-up care for our patients in general. And this will be a heavily focused area, and we could even potentially research it and do a study related to it in terms of quality metrics. Once again, it's basically length of stay, readmission rate, healthcare associated infections. Adding a discharge team, to me, is an incredibly important piece of healthcare that can actually improve all of our metrics.
Yeah, I think, just to reiterate, so many people don't fully understand maybe their discharge instructions, but are hesitant to ask additional questions or ask for clarification. And I think then we end up releasing them and there's a disconnect at that point.
A lot of disconnect.
Yeah,
Absolutely.
I absolutely agree with that, because the problem with when you're discharged from the hospital is that you don't know what to expect if it's a new issue, medical issue, when you go home, where you leave the hospital. So yeah, you don't know what questions to ask,
Yeah, that's certainly, I've been a patient in the hospital. My husband's been a patient in the hospital, and it's overwhelming. It's a whirlwind of information, and yes, you get your discharge instructions, and then, luckily I work in a hospital, so I can barely easily reach out to people like Dr. Hogan or my primary care physician and ask, oh, hey, what does this mean? Or what am I supposed to do now? But for somebody that doesn't have a relationship like that set up, oftentimes it just goes by the wayside. And again, like Dr. Hogan says, they just come back to the hospital when they start to feel really bad, instead of addressing, anything that's occurring sooner. So, there's a lot of improvement, opportunities and improvement for healthcare, but that's a whole other presentation.
Well, in addition to the transitional care clinic, does anyone have any other questions for Dr. Hogan about other health issues or COVID updates?
Well, I have a nosy question. How's is it still over 80% capacity in the Emory Decatur ICU?
Yes, and some of that is by design. We do accept transfers in here every day, purposely. But the COVID numbers overall are coming down significantly. And we have had these past few days, we've had significant relief. And really what we need every once in a while is just some room to breathe. And we've gotten it over the past several days. But again, so we do it on purpose. We bring patients in here on purpose. And the goal is that we want Emory Decatur to grow. We want to get bigger as the community gets bigger. And so we do accept transfers in. We don't want to ever be, say, at 50% capacity. That's too low. So some of it is by design.
Good questions.
Dr. Hogan, there's a lot of mixed messages we get about the severity of Omicron and whatever else is out there today, and whether the vaccination takes care of it and blah, blah, blah.
So a lot of the reason why there's mixed messages is because science takes, and medical science is no different, takes time. It takes us a little while to figure out new changes, and Omicron is no different. Any kind of variant is no different. Natural history of most viruses, however, is that they get less virulent or less deadly over time. And Omicron has shown that it's definitely less virulent, or less deadly, that is, than prior mutations. It can spread faster, but it doesn't get to the lungs as easily. And studies currently are showing that patients that have had at least the booster are much better protected than those who haven't. And of course, vaccinated patients are much more protected than those who haven't. Vaccines work. They have proven to work. The vast majority of patients in the hospital are unvaccinated. And the ones that are vaccinated usually have secondary issues that put them at higher risk. So the vaccines work. I am 100% convinced, and I'm also convinced that you should get a booster if you haven't already. And right now, companies like Pfizer are actually looking into another type of booster that specifically targets Omicron. So that's the problem. So the mixed messages, a lot of what you're hearing, are the vaccines that were created early on are not specific for Omicron, and they're not. And that's why Omicron was able to kind of still infect patients that were vaccinated. But our immune system has been amplified enough that it does provide protection, significant protection over those that are unvaccinated, even if you do get Omicron. And I got Omicron, by the way. So my whole family did, and we're all vaxxed and boosted. And I was ill for maybe a day, and then I was fine. That could be, take it or leave it. That could be a testament. I'm fairly young, I'm fairly healthy. I understand that, but I know fairly young and fairly healthy patients that were not vaccinated, got Omicron, and were in the hospital. And so vaccines work.
Dr. Hogan, what do you think about getting the fourth shot? For people who are over, like us, who are over 70 or immunocompromised in some way, especially after
I would
6
say
months.
at this point in time, sure, and that's what I was about to say. So after 4 to 6 months of time, your immune system wanes a little bit, and a fourth booster is most likely going to come out in formal recommendations, especially if that fourth booster, like I said, is created with the Omicron variant in mind.
Okay.
So yes, when I have a feeling those guidelines are going to come out very soon from the CDC, and then if they do, I would highly recommend that you get the fourth booster. And then after this, I'm hopeful that it becomes what we call endemic, like the flu, where every year you're going to have to get your COVID shot, just like you get your flu shot, in order to protect you from that year's variant. But it won't be as lethal as earlier forms of COVID were. So the fourth booster is coming. And if anybody's traveling abroad, a lot of countries out there are actually requiring a fourth booster, depending on when you got your third. So that's another push. And so you will definitely see language very soon from the CDC about that. And when it comes out and when they recommend it, I would recommend it as well.
It's not out yet?
I mean, this is the one thing I need to stress is these messenger RNA vaccines are completely safe.
Yes. But it's the fourth. If I needed to get a fourth shot, could I get it now? Like say.
I'm sure there are people give it to you. I could certainly find somebody that would give me the 4th shot. I
Okay,
know,
well, I
I
don't
know
need
I
it
could
right
get
now.
it. No, I mean, I would wait for formal recommendations to come
Okay.
out. And this is really kind of a supply issue. You know, we're still
Right.
trying to reserve a lot of these booster shots for the people that haven't gotten them yet. Now, granted, I've heard arguments that say, well, you could have gotten it by now, and if you haven't, tough luck, I'm going to go get mine. But there's still, I would always recommend, you know, for instance, the CDC, wait for their recommendation to come out before you get it. But again, you could probably find a primary care physician or any of the pop-up tent clinics that you see around the city would probably give you the 4th one if you wanted it at this point.
Great. Thank you.
Anyone else?
Dr. Hogan, this is Victoria. I want to thank you very much for what you just said, because now the one thing I will tell you, and I'm probably 99% sure that everybody on this call today has been completely vaccinated and gotten their booster. That's the one thing I have to give seniors credit for. We decided early on that we would follow the rules. We would do everything we could because we didn't want to get sick. And we're at a point in our life where we want to enjoy our lives, you know, and the things that we plan to do in retirement. So having said that, I do think it is important for people to understand, and because this is what I have to deal with all the time, is that with this Omicron virus variant, it is highly contagious. And we have had one member die from it who was vaccinated. So, but she had a compromised immune system and had been exposed to a lot of, you know, so there are things that can happen. But I just think it's really important for people to understand that this isn't over. They've got to continue to wear a mask, social distance, and, you know, follow the guidelines until what you said a little while ago, it becomes an endemic and not a pandemic. You know, so I'm so grateful for you for saying that out loud. Because see, I'm the voice all the time. I know they get tired of hearing me say, but I'm always glad to have back. Thank you.
And this goes right back to the transitional care clinic again. I mean, one of the beauties of clinics is it keeps you out of the hospital, because the hospital is a place where you can get infected. And so you want to stay away from highly trafficked COVID areas. And there's nothing more highly trafficked in COVID than a hospital right now. So the transitional care clinic would help provide care for those patients to keep them out of the hospital, and would hopefully help decrease our risk of infections, including COVID. But you're absolutely right. You should, even if you're vaccinated and if you had a 4th, 5th, 6th, 7th, 8th booster, we live in a different world now than we did before. Even when it becomes endemic, we've learned so much more. We probably should have been practicing some of the safe practices that we are doing now way before COVID even hit. You know, flu is no joke either. The flu kills 60,000+ people a year, and we kind of took it for granted. Just, we need to be more careful around each other, and we need to worry about each other and not just ourselves.
Thank you for all those answers. And thank you, Victoria, for what you reminded us about.
Every day, tragically.
I don't know, verbal seems to have a little more impact.
Well, I appreciate that. And I have to tell you, you know, because this is the reason we're not open. And it's so important for people of our age group not to be isolated, and, you know, and all the things that go along with that. But we can't open up until we get the population vaccinated, period. That's all there is to it. And we're just not there yet. And that's it. And we've done our part. Seniors have done our part, and I'm really proud of us as a generation, but we can't open up. So I think your message is really an important one. And I'm glad that there are people on this call. I know these folks on this call today, and they will help spread the word. And they'll say, Dr. Hogan said, instead of Victoria.
Victoria, will y'all be able to make this available to us?
I think Valerie's recording it. I believe so. And if yes, then I would say yes. And that's probably a good idea. And that way, Dr. Hogan and Beth and Elizabeth, with your permission, then we can share it later, perhaps to people who may have missed this presentation.
Absolutely.
Yeah, thank you. It's just so much to take in at one time.
Thank you,
It
Pete.
is.
A lot. Well, I don't have anything else. I don't think Elizabeth has anything else either. Thank
I'm
you for your
good.
time.
Well, thank you both for the presentation. I learn a lot every time I hear you guys speak, and just appreciate all of you members at Central DeKalb for allowing us to do these presentations on a monthly basis.
We're
Please
grateful to
keep
you,
the-
Beth. It wouldn't happen
Yeah.
without you, dear.
Well, I appreciate that. Keep the suggestions for topics coming. Just let me know what you want to hear each month.
Okay, I'll ask them in the email and see how many responses I get. I'll let
That
you
would be
know.
wonderful.
We wish you luck with the donations, and thank you for allowing us to be a part of that.
Yes, thank you so much.
Yeah, and
Thank you.
advocacy is a big part of helping us fundraise, even if you're not an actual donor. Letting other people know what we're trying to accomplish with this clinic and how it will benefit the community will help us in the long run. So we appreciate you guys continuing to share this message.
Well, we're glad to do that. Advocacy is such an important piece anyway in our daily life as seniors. So we appreciate this. Another opportunity, actually, for us. So thank you.
Absolutely.
Thanks. Take care.
Everybody be
well.
safe.
Take care, everybody.
Have a great day.
Wear that mask.
Bye-bye.
Bye,
Thank you,
everybody.
Bye-bye.
Hogan.
Thank you.